Welcome to your Health and Inequality class. This is our second lecture, and today we're going to be talking about the social determinants of health. I want to start the class by talking about what it means to think sociologically about health. So for sociologists, health is not just the product of our genes or biological outcomes. Health is something that is socially constructed. Sociologists are particularly interested in looking at two dimensions in which health is socially constructed. Sociologists have paid close attention to how health outcomes are the result of policies and institutions that we as a society have decided to support. Sociologists are also very interested in understanding how our taken for granted notions of what is healthy and what is not, and how the medical knowledge we rely on when confronted with disease is something that is shaped by our cultural beliefs and technological advances. It's also something that changes across space and time. These are two things that I want you to keep in mind as you go through the readings assigned for this week. So as I was getting ready for this class, I thought that a good entryway to talk about health disparities and those causes in the US would be to think about the US in an international perspective. So how's the US doing compared to other high-income countries? So despite the US is among the wealthiest nations in the world, it is far from the healthiest. Americans as a group fare worse in at least 9 health areas, such as infant mortality, injuries and homicides, adolescent pregnancy and sexually transmitted infections, HIV and AIDS, drug-related deaths, obesity and diabetes, heart disease, chronic lung disease, and disability. This report made by the Institute of Medicine concluded that the US has a pervasive pattern of shorter lives and poorer health. And this study found something very interesting too, which is that even Americans who are white, insured, college educated, and upper income, right? So wealthy people, even wealthy Americans are doing worse in health than their peers in other countries. This is very concerning, right? So why are Americans so unhealthy? So a lack of access to a healthcare system is one of the reasons. Unlike its peer countries, the US has a relatively large uninsured population and more limited access to primary care. Americans are more likely to find their healthcare inaccessible or unaffordable and to report lapses in the quality and safety of care outside hospitals. These graphs, for instance, show us how minority groups, especially Hispanic or Latino people, have less access to health insurance than other minority groups and white people. A second reason for the US health disadvantage are health behaviors. Although Americans are currently less likely to smoke and may drink alcohol less heavily than people in peer countries, they consume the most calories per person, have higher rates of drug abuse, are less likely to use seatbelts, are more involved in traffic accidents than involve alcohol, and are more likely to use firearms in acts of violence. This graph, for example, shows us how America has the highest drug death rate in the world. A third reason for the US health disadvantage are social and economic conditions. Although the income of Americans is higher on average than in other countries, the US also has higher levels of poverty and income inequality and lower rates of social mobility. Other countries are outpacing the US in the education of young people, which also affects health. And Americans benefit less from safety net programs such as Medicare and Medicaid, Social Security programs that can buffer the negative health effects of poverty and other social disadvantages. So this graph here, for example, shows us how the US is doing in terms of poverty rates, and it's not doing really well. And so a fourth explanation for the US health disadvantage are the physical environments. So in the US, communities and the built environment are more likely than those in peer countries to be designed around automobiles, and this might discourage physical activity and contribute to obesity. Right? This graph shows how the US is doing when compared to other high-income countries when it comes to obesity. As you can see, the US is a country with the highest rate of obesity. You can split this by gender, and it's the same result. So why are Americans so unhealthy? In summary, Americans are unhealthy because of lack of access to health system, health behaviors, social and economic conditions, and their physical environments. There is not a single factor that can fully explain the US disadvantage, but a combination of these factors is what can explain it. It's also important to note something very interesting that is mentioned in this report, which is that the tragedy is not that the US is losing a contest with other countries, but that Americans are dying and suffering from illness and injury at rates that are demonstrably unnecessary. Superior health outcomes in other nations show that Americans can also enjoy better health. So for now, let's move to the second part of the class. Let's talk about health disparities within the US. This is probably also not a surprise to many of you, but as you can imagine, racial and ethnic minorities, low-income groups, and gender and sexual minorities, all of these groups experience higher than average rates of illnesses, have a higher age-specific death rates throughout their life course, and are more likely to suffer from early onset of illnesses and more severe diseases than whites. The differences between minority groups and white people, the health disparities between them, are large and appear to widen over the life cycle. So this graph here is from a study published by the Stanford Center on Poverty and Inequality. This is from one of the readings in Stanford Today. And as you can see in Figure 2 shows the cumulative likelihood by race of the onset of a stroke, heart attack, and heart disease, respectively. These results show large differences between blacks and whites in the onset of these serious health conditions in adulthood. However, after accounting for childhood, family, and neighborhood factors such as parental income, birth weight, health insurance access, child neighborhood poverty rate, these large disparities nearly disappear. In other words, health differences are small when black and white children are exposed to similar family and neighborhood environments. So this is another graph that I thought that could serve as an example of health disparities within the US. Here we can see the prevalence of obesity by income, and we can see there is a clear pattern by race as well, and gender. So lower income women are more likely to be obese across all racial groups. This pattern is, however, less clear among men. Okay, so far we've been talking about health disparities within the US. We talk about health disparities in the US from an international perspective. And now we're going to talk about health disparities as a result of bias within academic medicine. And by academic medicine, I mean medical education and medical research. Okay, so this is from the Ansel article that I assigned for this class, the Bias, Black Lives, and Academic Medicine article. And in this article, he starts talking about the White Coats for Black Lives movement, right? People in this movement were protesting the bias, the systematic bias within academic medical centers and their impacts on Black lives. I'm going to read a quote from this article. We feel it is essential to begin a conversation about our role in addressing the explicit and implicit discrimination and racism in our communities and reflect on the systematic biases embedded in our medical education curricula, clinical learning environments, and administrative decision-making. We believe these discussions are needed at academic medical centers nationwide. So, what are these systematic biases that they refer to? So I want to start by saying that implicit bias refers to unconscious racial stereotypes that grow from our personal and cultural experiences. So in this article, Ansel and his team are talking about how there's an unequal treatment in the healthcare system in the US that is the result of racial profiling in medicine and medical research. And they say that this is manifested in two ways. So first, there's the case of doctors who have stereotypes based on the patient's race that can influence their clinical decisions. And secondly, in second place, despite the fact that physicians and medical centers do the best in trying to be equitable, we still see these black and white disparities and how they persist in patient outcomes, medical education, and faculty recruitment. The Institute of Medicine, for example, has concluded that for almost every disease study, Black Americans receive less effective care than white Americans. Implicit bias may also influence administrative decisions at academic medical centers, decisions from what services are provided to whether to accept insurance that serve the most disadvantaged members of society, to which neighborhoods to choose when establishing new physicians' offices. Implicit racial bias may also contribute to the failure to achieve greater inclusion of Black students in medical education. This graph, for instance, shows how the percentage of Black men among all medical school graduates has declined over the past 20 years. Implicit bias may also affect the recruitment and retention of Black faculty members in academic medicine. Only 2.9% of all faculty members in the U.S. medical schools are Black. Black faculty members are less likely than their white counterparts to be promoted, to hold senior faculty or administrative positions, and to receive research awards from the National Institutes of Health. Oh, okay, so I just wanted to add this interesting quote from Ansel and his colleagues, where they say that although there may be different drivers of poor recruitment, retention, and promotion of Black faculty members, the role of institutional bias and the climate for Black faculty at academic medical centers is something that deserves further research and scrutiny. Okay, so we've talked about health disparities within the U.S., health disparities from an international perspective, and health disparities within academic medicine. So now I just want to go back to what I was saying at the beginning of this lecture about how sociologists think about health and how sociologists emphasize that health is socially constructed. So we've been mostly focusing on how health outcomes are the result of policies and institutions that we as a society have decided to support. But now I want to talk a little bit about how our medical knowledge creates health disparities. Okay, so let's talk about health disparities as a result of our medical knowledge. So to give you an example of how medical knowledge affects the way we understand disease, I assigned Chapter 5 of Joanna Skepner's book, Knock Tonight, Migraine and the Politics of Gender and Health. This chapter in particular is super interesting because in this book she's been talking about how migraines, right, is a disease that is generally understood as a women's disease, despite the fact that men also get it. Throughout this book, she's been emphasizing how neurological models of migraine and pharmaceutical representations of the disorder replicate this kind of gender essentialism, right? And how, because of the fact that migraine patients are perceived as weak, temperamental, hypersensitive, they lack medical legitimation, right? So in a way, their pain that they're experiencing is not something that is oftentimes welcome or acknowledged by the doctors. So in this chapter, Dr. Kepner, who is a professor in the sociology department, by the way, so whenever you feel like it, well, not whenever, but if you want to talk more about migraines or cluster headache, you can just contact her and send her an email. She's wonderful. But as I was saying, in this chapter, Dr. Kepner decides to compare migraine, the social construction of migraine vis-a-vis cluster headaches. And the research question that is guiding this chapter is how migraines might be understood if they were assumed to be a men's disease. Will medical description of this disorder look different? will patients experience more social or medical legitimation? And so what Kepner finds is that the descriptions of cluster headaches are full with metaphor of masculinity. She finds that masculinity, not femininity, is what is guiding scientific research and non-scientific understandings of cluster headache. Masculinity is invoked by comparing its aggressive symptoms to the passive retreat of migraine. So, cluster headache is a perfect example of medicalized masculinity. And what is so rich about this article is that you can see on the data that she collected, on interviews and on the descriptions of the disease that she finds in medical texts, how this masculinization of the disease is perceived as being unproblematic, right? So I assigned this test because I wanted to give you a glimpse of how health disparities are created by the ways in which we understand disease. And this is something that we're going to be talking about more in depth next week when we talk about the social construction of disease and framing illnesses. But for now, please make sure that you finish reading Joanna's chapter. Okay, so now we got to the end of the lecture. These are the quiz questions for today. Please read them carefully. And as I said before, you can try answering them and then send me your answers and I'll give you feedback. This is not going to be graded, but I think this is a good exercise and it's going to help you to prepare for the exam. And so finally, for this class, I want you to watch the first part of this documentary called Unnatural Causes. It's a documentary about health disparities in the US. So it's super relevant to the topics we've been discussing today. This documentary is available on the library. That link that you can see there should be working. But if it doesn't work, if you go to the Sakai site under resources, you're going to see a link to this documentary. So please make sure that you watch it. Only the first part, which is, I think, about an hour long. Okay. Okay, and finally, these are the readings for next week. So you have to read the Brown article, Naming and Framing the Social Construction of Diagnosis and Illness, the Macharek article, Beyond Fact or Fiction on the Materiality of Race in Practice, and the Stephen Epstein article, Impure Science, AIDS Activism and the Politics of Knowledge. All these articles are available on Sakai. I know that the Sakai site might not be working tonight and tomorrow, so I'm going to send you an email with all those readings so you can watch it. Okay, that's it for today. Please let me know if you have any questions. Just send me an email. Bye.